Okay, so we'll go ahead and get started. We might have some people joining us as we're speaking. And then I wanted to let everybody know that this would be recorded. So you're able to go back and watch it on our website, and I'll send an email out once it's available. My name is Caroline Johnson, and I'm the executive director and founder of Twisted Pink. We are a nonprofit based in Louisville, Kentucky, that has a mission to provide hope and connection to people living with metastatic breast cancer by funding bold breakthroughs in research and awareness of the disease. We have multiple programs in order to do this. I encourage you to take a look at our website to look at some of our programs that we offer. One of them is an educational program that we're doing this evening. We do these every month, and we invite you to join us every month for different topics throughout the year. And I'm just glad that everybody's here tonight. We had 100 people register, and we still have some people coming in. So we're hoping this will be a very good educational opportunity for you. We're proud to have our topic this evening is circulating tumor cell testing and biomarker monitoring. Our speaker is Jennifer Davids. She is a PhD and a graduate of the University of Florida with a focus on drug development and genetics. And she's the director of patient advocacy and community education at Menarini Silicone Biosystems, with 10 years of experience in supporting cancer researchers, patients, and physicians, with a focus on breast, prostate, and colorectal cancers. And I'm going to go ahead and turn the presentation over to her. We will have questions and answers at the end. If you want to put questions in the chat as she's speaking, I will go over those at the end and read those and then give her the opportunity to answer questions. And if you click on the top of your screen where it says view and click on speaker, then you'll be able to see just the speaker on your screen. And that is all I have for right now. I'm going to go ahead and let Jennifer speak.
Well, thank you for the introduction, Caroline. I'm Jenny, or Dr. Davids, depending on kind of how formal you like to be, but please feel free to call me Jenny. I'm going to walk through some slides on some pretty complex topics, but one of the things that I try to specialize in is using as plain of language as possible to try to clarify some of these really similar sounding analytes and technologies, because even for people like me, I might have a PhD in immunogenetics, but it's so much easier to follow a conversation if it's in relatively accessible language for me. So I'm going to present some slides. If you have questions, obviously, please write them in. We'll go back to them later. I have more slides available on my computer if we have other specifics we want to get into. So let me share screen here, and we will get going. So I'm going to talk today about a minimally invasive, we don't want to say non-invasive, but minimally invasive liquid biopsy test for circulating tumor cells. So let's define some terms even from the get-go. So a liquid biopsy is effectively similar to a tissue biopsy or a fine needle aspirate, or you may have heard of a tumor biopsy before. Those typically are going to be of cells that are in tissue. A liquid biopsy in our discussion today is going to be blood, but it can be a variety of other liquids like cerebral spinal fluid, pleural fluid from the lung, ascites from the abdomen. In theory, we've had researchers do urine. People can do saliva, maybe not so much with this test, but all of these liquids provide important information about your whole body's well-being, right? So I want to consider a forest, and I promise this is not just an excuse to show you travel photos, but if we think about forests, most of us have probably visited one at some point, and they're consisting of a wide array of different components, right? We've got trees. The trees can be deciduous, so they shed their leaves. They can be evergreens. They could have lakes and wildlife in them. So if we think about a forest as being like a body, it is a huge diversity of information that can be broken out into component pieces. So some of those component pieces, if you're walking along a forest floor, are going to be things like twigs, right? So nothing fancy. I went out in my driveway last week and I found this assortment of twigs, and they're all a little different, right? Some of them are longer, some of them are shorter, some have rough looking bark. Some from my cherry tree look like they have very smooth bark. There's some with pine needles that gives us a little bit more information immediately. But if I was to ask you to guess, other than the pine needles, what tree did these come from and what does the forest look like? It's going to be very hard to extrapolate. And these twigs, branches are similar to what we're going to talk about today as circulating tumor DNA. So you'll hear circulating tumor or cell-free as a prefix in front of DNA or RNA in a lot of these tests. It's a little bit like a rectangle and a square. And we'll have written definitions of some of these terms later as well. But circulating tumor DNA is a subset of cell-free DNA. And that basically means we know that there's DNA and RNA in whole cells. So you can break apart a cell and look at these things. But as cells die, they also release these nucleic acids, the RNA and DNA, and they degrade into different size fragments. Those are just floating around in the blood, and that's what makes them cell-free. Now, if we think about leaves, which also fall from trees, leaves provide a diversity of information that is a little different from what you might extrapolate based on a stick. If we look at these leaves, they're in different sizes, different shapes, different colors. On the right-hand side, I have 3 maple leaves, right? One is green, it's a little larger. We've got a bright red one, and then there's a little itty-bitty kind of red and orangey yellow one. So from looking just at this diaspora of leaves, you could extrapolate, rightly so, and it's November, that it's fall, right? So we do get additional information from these leaves, and the pine needles, again, are a pretty clear indicator about what kind of tree it comes from. So these leaves are a little bit like circulating tumor cells, like ctDNA. It's shed from the tumor, but these are whole cells that are intact and are out in circulation where we can pick them up from just a blood draw. So to just kind of reprise what we're looking at is if a forest is like a body and a given tree is perhaps like a tumor, then we might have in the bottom left, our sticks and branches might be the circulating tumor RNA and DNA. The shed leaves may be like our circulating tumor cells. And we'll talk a little bit later on some of those non-shedding trees like an evergreen that do not typically shed these things. So to break it into a little further detail, circulating tumor cells. So again, these are the whole cells. If you look on the diagram on the left, we have a primary tumor. It is releasing cells into the bloodstream, which are then the circulating tumor cells. And these circulating tumor cells are thought to be the seeds for metastasis later. So if you look in the bottom left, you can see that these cells are exiting circulation, and they are perhaps creating a new metastatic site. This is not a 1-to-1 ratio by any means. There are certainly circulating tumor cells that just circulate in the blood and die and get cleaned up by your body's immune system. But we do think that they can be a seed for metastasis, and they can also circulate as a cluster of cells. The test we're going to talk about today has 20 years worth of clinical data and FDA clearance behind it. But we know that these circulating tumor cells are a very strong indicator of prognosis and overall and progression-free survival when you look at the total number of cells in a given milliliter of blood. Most forms of liquid biopsy, and this will kind of make sense, we'll look at another way of thinking about this, reflect tumor progression earlier than imaging alone. We know that imaging has a number of strengths and weaknesses. One of those weaknesses is that oftentimes forms of imaging struggle to detect tumors under about a centimeter in mass. And so any kind of liquid signature, the ctDNA, the CTCs, will detect that a little earlier. The other thing that's really important to understand about circulating tumor cells, especially when we're going to talk about biomarkers a little bit today, there are clinical studies out that show, it's been well documented across tumor types, across decades at this point, that a primary tumor, for instance, to use a biomarker we'll discuss more that you're probably very familiar with, like HER2, a primary tumor might be HER2 negative, but because we know that individual cancer cells are frequently switching on and off different genes, it is relatively, it's about 40% of patients, will have circulating tumor cells that would then perhaps be HER2 positive or positive for another biomarker. So these circulating tumor cells can represent a global mutational landscape. And we know that knowing the overall picture, if you've got that HER2 negative primary tumor and a HER2 positive CTC, well, is that then an indication perhaps there's an opportunity for intervention with a HER2 targeted agent? And we do have some literature that indicates that that does increase overall survival. So now switching back, because we're going to talk about these comparisons, it's really easy to get kind of these pieces confused to the circulating tumor DNA. Again, we're looking at our sticks. Here in this picture, I tried to organize them by characteristic just a little bit more. You can see kind of toward the middle, there's some shorter, smoother ones. There's some bendy ones on the left. There's a really short one up top. These circulating tumor DNA and RNA fragments, as I mentioned, they're small pieces of nucleic acid that are released by dying cancer cells and are just circulating in the bloodstream. These are still very useful pieces of information, even though they're not whole cells. You guys are probably very familiar with our ability to do things like next generation sequencing or PCR polymerase chain reaction tests to look at genetic mutations. So ctDNA or ctRNA is a great way to detect genetic mutations and biomarkers that help guide therapy selection. As I mentioned, any of these liquid biopsies, but particularly ctDNA, is a great way to detect the presence of you'll hear MRD referred to both as minimal residual disease and measurable residual disease. These are effectively just a kind of an early signature that lets your care team know that that tumor is still present. Perhaps you're in remission and there's been no signs and symptoms, and all of a sudden there starts to be a little bit of a ctDNA or CTC signature that helps us know that recurrence is happening before it be detected on something like imaging alone. Some of this mutational information will help predict the likelihood of cancer landscape, and these nucleic acid markers also help understand a global mutational landscape because cells from different tumors at different sites are dying at any given time as our immune system and our drug regimens help battle these tumors off. So to kind of put this in a table format, you can kind of see I kept like the leaves on the left-hand side, the stick on the right-hand side. If we look at just the comparison of these two tests, these both typically will come from a blood sample. From circulating tumor cells, it's that whole cell. We can do the count, and that's what we're going to focus mostly on today. But in theory, we can do DNA and RNA analysis. We do protein analysis through some of the biomarker analysis. For the ctDNA and RNA, we're looking, I have a little typo here, but it should be DNA and or RNA fragments. The turnaround time on a whole cell enumeration for circulating tumor cells is usually about 3 days from when we receive the tube of blood. Circulating tumor nucleic acids are typically weeks before results can get back to you. They both help understand biomarker status, and they both have challenges that are unique. Circulating tumor cells overarchingly can be hard to isolate. Not every cancer patient will ever shed circulating tumor cells. So those are kind of my evergreens here in this analogy. Patients, this is one of those mysteries of science, right? People have been trying to kind of figure this out for a while, but this is why this test is not diagnostic. We know that there are patients who may have a heavy tumor burden riddled throughout their body, and they just never shed CTCs. Circulating tumor DNA is pretty omnipresent, but sometimes it's available in such low quantities that it's very difficult to measure. And sometimes it requires a baseline tissue sample. So if, for instance, you're a patient who's in remission, there's really no tissue sample to go back to right now, which is good. But it does make that type of testing much more complicated. I'm not going to talk much about it today, but we do also in our portfolio have the ability to do cell-free circulating tumor RNA and DNA sequencing. The RNA is less common in the market. We can do these from tissue and bone marrow and then peripheral blood as well to get into that liquid biopsy space. The main focus today, though, is the cell search circulating tumor cell technology. This is kind of the industry leader. We've been FDA cleared for metastatic breast, prostate, and colorectal cancers for over 20 years. And there's a lot of research in circulating tumor cells kind of across the industry. So to look at the current landscape of testing, I want to break this out into kind of 4 modalities to understand how these things work together. So we have things like molecular testing, right? This is going to be PCR testing. This may be ctDNA analysis. And this helps match specific targeted therapies to a unique patient's profile. So if they find out that you have, like a BRCA test might be, well, actually BRCA is better in the other category. If you had like a ALK rearrangement or similar, that would kind of fit in this molecular testing where they're going to find then an ALK targeted agent or a HER2 targeted agent and work that into your treatment profile. Genetic testing in breast, obviously, we've heard a lot about BRCA testing, and this is looking at hereditary risk toward the family. I mentioned imaging and its kind of slight drawback of really being able to do visualization of masses over a centimeter, and that leaves a space for what we're calling cellular testing. So this cellular testing is looking at those holistic cells and understanding the total number of cells present, because serial monitoring, so monitoring over time, helps understand the trends in what your cancer is doing. And there's a tremendous amount of clinical research around this circulating tumor cell testing. We can use this test to detect changes in prognosis at any time. Because it has that global mutational landscape, we can better understand the bigger picture of what your cancer and what your tumor is doing at any given time, because we know cancer is savvy, right? You get a treatment and it responds and it evolves. So being able to monitor this in an up-to-date way and analyze those trends over time is really helpful and provides insight into progression-free survival and overall survival. So I wanted to show you guys just kind of some images of what these look like. Now, these do look a little bit like, maybe some astrophotography, but we've been working off of the same platform for 20 years, gathering all this clinical data. So on the top are circulating tumor cells, and these are cytokeratin positive. So it's a structural component of the cell. They are positive for a nuclei, which is what our DAPI marker looks like. And we want to make sure that it's not contaminated with immune cells. So we are looking at a marker to exclude leukocytes. Leukocytes are actually on the bottom, so you can see they look pretty different in that left-hand column. The rest is what we'll eventually use for our analysis of things like biomarkers. So to come back to kind of some of the important pieces here, and I'm going to talk about trends and then show you specific breast cancer data. We know, based on all the clinical research, there's a pretty firm cutoff in breast cancer of 5 circulating tumor cells. There have been studies done in recent times that help us apply these in new ways as well. So to show you kind of the patient care scenarios that I think are most relevant here, and then we'll talk a little bit about some of the newer implications. On the left-hand side, we're going to look at a scenario in which, in the raspberry, a patient at baseline, so on the left-hand side is a baseline measurement, and then we're going to look at iterations over time as we move to the right. In the raspberry, there's a patient who had above 5 circulating tumor cells at baseline and did not really respond, did not drop below that cutoff while therapy progressed. These patients are going to have the shortest overall survival and progression-free survival, and I'll show you some of those numbers on the subsequent slides. But on the bottom of this line, we're looking at a patient who had a below baseline cutoff and over time progressed to above cutoff. These patients typically have the second poorest overall survival and progression-free survival. And that might sound a little gloom and doom, but what we're hoping is that by monitoring these scenarios on the left, that information can help a care team make new decisions, and that results in the scenarios on the right. So on the right, we have a raspberry to kind of lime scenario where a patient may be above at baseline or at a different point in therapy. A new line of therapy is successful, and you can see the circulating tumor cells drop below baseline. This is an improved overall survival and progression-free survival. And the best scenario is if somebody has below 5 circulating tumor cells at baseline and stays below throughout the course of therapy, these patients tend to have the best overall survival. So I tried to keep the colors fairly similar here. So if you had in our raspberry the above cutoff at the baseline and at the end, you have a survival typically of about 4.1 months. This was a very aggressive cohort. And if you had the lime, those patients now on the top right had about 23 months. And you can see that in the green and the orange, the like lighter lime green and the orange, those are the patients that had changing circulating tumor cell counts that went above or below the cutoffs. And so you can see that this data stratifies to reflect those movements. So if your circulating tumor cell was increasing, we get the kind of orange scenario where below baseline to increase had a survival of around 11 months, and the inverse about 20. So this information is really meant, as I mentioned, to help us guide therapy decisions. It also helps us understand sometimes a little confusing data. So this is a study where we looked at CTC enumeration with unclear imaging or imaging that was just discordant from what seemed to be going on. So on the left-hand column, we'll have imaging with the first two being favorable, and the second two being unfavorable, and then circulating tumor cells. And now we're going to look at these survival. So if you had favorable imaging and favorable circulating tumor cells, the median overall survival was approaching 2 years. If imaging was favorable, but the circulating tumor cells were high, that median overall survival was 9.2 months. So again, imaging thought that things were okay, but the circulating tumor cells said something is not okay here. If we look where both of those indicators are unfavorable, survival was about 6 months. But again, importantly, if imaging was unfavorable and said, it looks like there's progression, but CTCs said things look okay, that survival was about 20 months. So this is an additional layer of information that helps enrich this. The other piece, and I have the studies where we've started to kind of update some of our understandings, is this was all originally cleared for metastatic breast. There's been a lot of studies, and we offer a CLIA lab-developed test for earlier breast cancers rather than just a metastatic setting, and for the biomarkers. These counts in any of these settings are still very helpful when monitoring trends over time. They also allow us to stratify aggressiveness of breast cancer in metastatic breast cancer. There are quite possibly, the data is still a little early here, but there's quite possibly two pretty pronounced phenotypes of breast cancer. And I unfortunately don't have a specific slide on this, but I thought it was important to share with you all that there's an aggressive form, right? Progresses quite a bit faster, and that is typically stratified by greater than 5 circulating tumor cells. And there's an indolent form that has below 5 circulating tumor cells. And they've shown things like for patients that have the indolent form, fewer than 5 circulating tumor cells. This was a study looking at by Shalane Goodman, who was then at the Northwestern University. If you had radiation, it didn't really help. Compared to patients who had greater than 5 circulating tumor cells, where you saw a marked impact that radiation did help. And there have been newer trials that show if you give patients with more than 5 CTCs an aggressive line of therapy, they benefit better than those who had few CTCs. And this probably makes really good sense because we're able to now use circulating tumor cells to start to inform quality of life decisions. If you've got high circulating tumor cells and it's a high risk scenario, kind of throw the kitchen sink treatment-wise at a patient. And if they've got a lower risk and the lower circulating tumor cells, let's take the time and do complete genomic profiling, figure out mutational status, and look at what is best for quality of life and what is most appropriate for treating. So that's kind of exciting stuff. So I know we talked briefly about HER2 as a biomarker, but we also do have a couple of other biomarker tests. So we have ER, which is a common marker for breast as well. We also do offer PD-L1. This marker is usually only in play for metastatic triple-negative breast cancer, but we do also offer that biomarker. And then we have a lung biomarker as well. And I know I spoke to our specifically FDA-cleared tests for metastatic breast, prostate, and colorectal, but we also have lab-developed tests that cover a wide variety of other cancer types. These are pretty easy to order logistically. We work with your physician to set them up on a portal. We can then ship a collection box with our cell save or cell rescue tubes, depending on the type, to either be sent to your physical location or the doctor's office. We do have some patients with limited mobility, right, or limited ability to just get to the office, childcare, structural challenges, whatever. These tests can be drawn by a mobile phlebotomist. or they can be at your doctor's office, whatever works best. Regardless of who draws the blood, the sample is basically FedExed to our lab in the greater Philadelphia area. And then we are going to make those results available to the physician typically within 2 to 3 days. And so you can kind of see just a little bit of a visual workflow across the bottom. And we try to get those back as quickly as possible because it's, you know, urgency is a great thing. We do send this format of a test typically to the physician, and they've got the cancer cutoff types across the bottom for easy reference. And then this test is also really well covered by most major insurers. So that's a really nice thing. We do have some financial assistance available. We do have a cash pay model for people who are without insurance. And at least for 2024, I know is ending much more rapidly than I expected. The cash pay price for circulating tumor cell tests in the United States, these are prescription only tests, is I believe $650. The biomarker for HER2 is $750. So although it is well covered by insurers, we do like to try to have some transparency around because we're always worried about financial toxicity in the industry as well. So between circulating tumor DNA, circulating tumor cells, we hope that the breadth of data available to us through these testing modalities helps all of us get the bigger picture, right? And not to lean too heavily into it, but we often lose sight of the literal forest, right? And the whole patient because we get kind of lost in staring at the trees and the tumors themselves. So this is just a great reminder for us to all step back and think about all of the iterations that are present here. So I know that was a lot of material, and I am really eager to answer any questions you have and kind of dive into the things that are most important to you. So.
I
So,
have a question.
oh, go ahead, Sarah.
Hi, my name is Sarah. I have estrogen receptor positive, node negative, stage 1A breast cancer that was removed via mastectomy. And I didn't tolerate the Arimidex, so I'm just not taking that stuff anymore. And I'm taking a test that I think is similar to your test, but it's probably a different company. It's Signatera.
Sure, that's a ctDNA test.
Okay, I just want to make sure I was understanding the difference between the tests. So every time I've taken this test, which is like 3 or 4 times now, the score comes back 0, which is great. But at the top of the thing, it says 16 assays were not able to be identified from, I think they mean my sample. So they have a sample of my original tumor and they're comparing, like what they're seeing in my blood to see if there's DNA from that tumor. And my question is, because I asked the doctor this, but I don't think he answered it like good enough for me. Okay, so if I'm getting a message that 16 assays are not able to be identified or measured, I don't know how many assays they're looking at, but I'm a psychologist, and if I was testing somebody on a, let's say, personality measure, and there's 20, things we're measuring and 16 of them are not measurable, I'm not going to get a lot of good information from that test. So what does this say to the specificity or the sensitivity of the test?
So they're great questions, and I would urge you to reach out to Signatera directly because I'm not as familiar with how their test works.
Okay, so your test wouldn't have that message.
No, because Signatera is a proprietary technology, and only a
okay.
Signatera rep can give you that information. But I agree with you; it is really important. Like you said, if 16 to 20, that's not very helpful overarchingly.
Right. Well, it said 16, but I was just giving an example. So,
Right,
every
no,
time
I
I
know.
see
If it's
that,
16 of 1600, that's not such a
right,
problem.
maybe
Yeah,
I should just call them, like the company and ask somebody at the company directly because my doctors are like, oh, don't worry about it. You're great. You have 95% chance of recovery, da, da, da. But since I come from a social science background and I see 16 things were unmeasurable,
right.
that raises a red flag for me. And so
Yeah,
that's kind of
Signatera has
why.
they have a great patient website as well, and you may be able to just fill out like a question form on there and get that answer.
Okay. But well, anyway, thank you for your presentation today because I
Of
didn't
course.
really have much of an education into it. I kind of understood on the surface, but I really appreciate you explaining this to us all. And your slides are great, and so is your allegory.
I just came up with it last week, so I'm really excited to hear that because I've been talking about this stuff for a long time, and I was just like out for a walk, and I was like, you know what? Leaves.
Well, I was on a walk when this presentation started. I'm home now, but anyway, thank you so much. It's very explanatory, and you're taking an hour out of your day to describe and answer questions. So thank you so much for being here.
Oh, it's my absolute pleasure.
Thank you.
So we do have another question in the chat, and I'm just going to read it. How to ask my oncology office to start testing and tracking my CTCs, and she's a metastatic patient, she or he, I'm not sure. It says I'm a metastatic patient.
Yeah. So there's a couple of ways. So we have a great website that is patient-oriented called www.yourcancercounts, it's plural.com. Your browser may tell you there's a redirect notice. It's just because we host it on our Ceros digital content platform. So it's a promise that's not been hacked, at least not as of today. So on yourcancercounts.com, there is a provider list. Now, we used to sell this whole big instrument, the cell search instrument, to medical offices and research institutions. And we switched models during the pandemic, right? Everybody was in a little bit of an upheaval. So now we do it as a send-in test. So even though we've been around for 20 odd years, a lot of physicians aren't familiar with this and are not ordering with this yet. So this is not an uncommon scenario. There are two ways we can go about doing this. One is we've embedded my team member, Jen Pushka, who's also on this call. She's responsible for the beautiful layout of that website. And we have some resources already embedded in the website. Patient guide, there's a video that goes through the circulating tumor cell testing, generally how it works. And we have a contact us form as well. So you're welcome to reach out to me through the contact us form, and I can provide you additional resources, but I will also do things like reach out if you want. You can introduce me to your physician. I can have myself or my sales team or my medical science liaisons and our med affairs folks work with your physician's office to educate them on the benefits of testing. We do have some that just their health system doesn't want to add another test vendor. So we do run into some hesitancies around that, but anyone in your state who can legally write a prescription, so maybe your pharmacist, maybe your primary care provider, if your oncologist or other specialist is not interested in bringing this test on board, it may be worth educating another physician and bringing this to them. But we're certainly happy to directly help as well as just providing general information to give them that little bit of boost to incentivize them to do this.
And then I had a question about the favorability chart that you put up. Does the favorability in circulating tumor cells change over time, or does it remain the same based on the original blood draw?
So it absolutely changes over time.
Okay.
So the original blood draw is one data point, right? So we know that if you were, let's say, we typically suggest that people use a risk-informed scenario. So if you've got a high-risk tumor type, you might be monitored more frequently, let's say every 6 weeks or every 6 months. We think that it's important for the patient and the provider to make this decision together, because sometimes a provider might say, let's do it every year, and the patient might say, I'd rather have it every 6 months, or some kind of similar conversation. So for a lot of patients who are in a low risk tumor type, they might just get an annual monitoring, but each of those is a data point over time. And it's not always that you see just a downward trend or just an upward trend. It's a little complicated to put in a presentation like this, but it's not unusual to have CTC lines that hopefully aren't quite as complicated as the stock market, but somewhat resemble that. And we know that those tumor types evolve and escape, right? I'm sure you guys have talked or heard about escapability of circulating, or excuse me, of tumor cells in general, because it's not sentient, but it's an alive little being, right? Like you treat it with something very effective, and if two cancer cells in that tumor have a mutation that protects them from this treatment, those two are then going to go on and have the new tumor will form from those two little mutants. So each time you have this blood draw done and the circulating tumor cells enumerated, it gives a snapshot in time and helps understand, okay, we went downward from the last time. Is it above or below cutoff? And then the next monitoring instance, is it above or below cutoff? And what kind of decisions do we need to make from there? So in a remission scenario, you might have the blood test done as a part of your annual monitoring. It's a 0 for like 8 years, flatline. We love it. But all of a sudden, it starts to creep up and there's 2 or 3. This is an earlier sign of remission, as we talked about with any form of liquid biopsy. So these things do change over time, and although we don't have a specific frequency recommendation, it is really useful to have these observed over time and extrapolate from the trends.
So there's no other comments or questions in the chat. Does anyone else have a question they want to ask? If not, I'll just say that we will put this recording up on our website, and I'll send everyone the link if you want to go back and watch it. And we'll also include, with the permission of our speaker today, a way to reach out and ask more questions. And we want to thank you so much for being here and educating us on this topic. It's very important. So thank you so much. We appreciate it.
Welcome. It's a pleasure speaking with y'all. And for those that are
Thank
watching
you.
this later, please feel free to reach out with questions. I'll be happy to answer them.
All right. Thanks so much.
Thank you.